All right, folks, I am back and I'm going to go ahead and share my desktop again or my presentation. And let's go ahead and get started again. All right. So on the previous slide, we looked at the acronym strokes happen. And so we understand some of the modifiable and non-modifiable risk factors. So continuing on, as we know, strokes are a medical emergency and must be attended to very, very quickly. And so another acronym that we look at or something we think about is happen suddenly, and which essentially means that we have to act very quickly because act fast to save brain cells. Meaning we must call 911. Don't try to put the patient in the or the client in a vehicle to haul them off to a hospital. Call 911. Much more safer, and they can start a therapy pretty quickly. You don't want to get into a vehicle and you're panicking, and then you get into an accident. So anyway, so make sure you call 911. Another acronym we look at is called FAST. All right. And also take a look at table 57.1. It speaks to what we're getting ready to discuss as well. This is very important because the patient and caregiver teaching, as far as the acronym FAST is concerned, being in kind of an early warning sign, if you will, for stroke, and they must be taught this. All right, so that they can do what needs to be done quickly. FAST is an easy way to remember the signs of a stroke. Students should actually include the following information, this acronym FAST, in your teaching plan for a patient at risk for a stroke and the patient's caregiver. They should understand this very well. So when you look at the F as in Frank, facial drooping, in other words, does one side of the face droop, or is it numb? Ask the patient to smile. Is the smile uneven? Is it symmetrical? If it's uneven, there may be a problem. Of course, it can be cerebral, no, not cerebral, Bell's palsy as well. But again, you're looking at everything. The A stands for arm weakness. Is one arm weak or numb? Ask the patient the person or the client to raise both arms. Does one arm drift downward? There's also speech difficulties. Is the speech slurred? Is the person unable to speak, or are they hard to understand? Ask the client to repeat a simple sentence, such as "the sky is blue." Is the sentence repeated correctly? And of course, the T is time. Time is critical. If someone shows any signs of any of these signs, even if those symptoms go away, you should still call 911 and get this person to a hospital ASAP. We'll talk about this as well, but time is critical because if it's an embolic stroke, which we'll hopefully find out by way of a CT scan or MRI, then we want to start the TPA therapy ASAP, or STAT, shall I say. Because we can give this patient, or we can reduce any disability that this patient may otherwise experience. All right. You always want to note the time when the signs first appeared. All right. Now, so if it appeared at 10 o'clock, let me back up. Let's say 5 o'clock in the evening, and they're at the facility at least by 5:30. Then you want to let them know that, hey, I first noticed this at about 5 o'clock. And so the healthcare team knows they have until about 9:30 to administer the TPA. Now, if someone goes to sleep and they wake up the next morning with those symptoms, we typically go by the last time or the time that they went to sleep. We use that time. So if they went to bed at 12 o'clock and at 6 o'clock in the morning, they woke up with these symptoms, then we have to go back to 12 o'clock. And so in that case, the patient may not be able to receive the TPA therapy, because it has to be given within a certain time frame. Let's see. That came through. So some signs and symptoms of, or manifestations of a stroke, in particular aphasia, the different types of aphasia. We have, well, you guys already know what receptive and expressive is. There's also a mixed aphasia, meaning both receptive as well as expressive. Then you also have the global type, meaning complete inability to understand or to produce sleep. Not sleep, but speech, excuse me. Now, aphasia occurs when a stroke damages the dominant hemisphere of the brain. So if your right brain is dominant, and if the stroke damages that part of the brain, then it is likely that your patient may experience aphasia. Now, the left hemisphere is dominant for language skills in right-handed persons and in most left-handed persons as well. Language disorders involve expression and comprehension of written and spoken words as well, so keep that in mind. And look at also here where it talks about Wernicke's area. That's when we get into the comprehension of the speech. And of course, the Broca's area, or the motor speech area, is referred to as the Broca's area. So keep that in mind as well. Let's see. All right. Trying to get my mouse over there. All right. And so some other clinical manifestations of a CVA, as you can see, these symptoms here. Many stroke patients have dysarthria, a problem with the muscular control of speech. Think about the Broca's area. Impairment may involve the way it may affect how they pronounce the words, their articulation, as well as phonation. Dysarthria does not affect the meaning of communication or the comprehension of language, but it does affect the mechanics of speech. In other words, that motor ability to actually speak. And then there is spatial perceptual problems. Those who had a stroke on the right side of the brain are more likely to have problems with spatial perception orientation. However, this can occur in people with left brain stroke as well. When people or clients have spatial perceptual problems, this deals with problems they might have, such as agnosia, and this is inability to interpret sensation and hence to be able to recognize things. And then they also have apraxia, which is difficulty with skilled movements, even when a person has the ability and desire to do them. So they can't carry out any thing that requires a skill, if you will. And just go ahead and take a look at these other definitions. Again, dysarthria, unable to speak clearly due to muscle weakness. They're basically hard to understand. Apraxia, where you can't perform voluntary movements, even though muscle function is normal. Also, there's agraphia, loss of the ability to write, alexia, a loss of ability to read, and doesn't understand or see the words. Then you also have agnosia, again, doesn't understand sensation or recognize known objects or people. And then we have dysphagia, which is swallowing, and then hemianopsia. They have limited vision in half of the visual field, which is one of the reasons why we tell these types of patients who can't see on a particular side of the body to scan the whole or the entire area to make sure they don't miss anything. Let's see, let's keep moving. Got a feeling this might end up being three. Three presentations, separate presentations. All right, and so here we want to get into the diagnostic test that you will see these patients require. When manifestations of a stroke occur, diagnostic studies are done to confirm that it is a stroke and not another type of brain lesion. Could be a tumor that has caused a stroke. And also to identify the likely cause of the stroke as well. And also take a look at table 57.6 and 57.7 regarding these diagnostic tests. Now, diagnostic study results also guide decisions about therapy. It directs us to which way we should go. For example, if someone has a CT scan of the brain and it is an embolic stroke, then that would tell me that TPA is the treatment of choice. The flip side of that is if someone has a hemorrhagic stroke, TPA is never given in that case because they would cause more bleeding. A key assessment to determine the time of the onset of symptoms. We must know when the symptoms occurred. This is important for all types of strokes, especially ischemic strokes, since the time can affect the treatment decisions. In other words, if the time is outside of the TPA criteria, then they won't get the TPA. So also glucose levels to rule out hypoglycemia. Make sure you check these patients' blood sugars first because signs and symptoms of a CVA might really be a hypoglycemic reaction. So you want to be able to distinguish between the two. Now, there is also the secondary assessment. Well, the secondary assessment does include a more comprehensive neurological assessment. There's a primary assessment, and then you have the secondary assessment. Now, the primary assessment tool, we must ensure that we evaluate and document the patient's neurological status, especially in those with an acute stroke. And we essentially use the National Institute of Health Stroke Scale, or NIH stroke scale. And essentially, this particular tool, it measures stroke severity. All right, and so take a look at table 57.11 for an example of the NIH stroke scale. This tool is a predictor of both short and long-term outcomes for stroke patients. It lets us know what we can expect in the short term and the long term. It also serves as a data collection tool for planning patient care and exchanging information amongst healthcare providers. All right, and then we have the CT scan of the head, which is usually done first because it is a very fast diagnostic tool. The MRI could take a little longer, and because time is brain, if you will, then we want to perform the quickest test. CT scan, pretty accurate test, but the MRI is much more accurate. But they generally do a CT scan of the head, of the brain. It might be non-contrast, and it would tell us if it's an embolic versus hemorrhagic. If it is embolic, you give TPA. If it's hemorrhagic, you do not. If it's hemorrhagic, these patients might end up going to the OR for a craniotomy to relieve the pressure that can cause increased intracranial pressure. Now, with the NIH scale, it is a 15-item neurologic examination used to evaluate the effect of an acute stroke. Now, the scores, the total scores on this tool range from 0 to 42. The higher the values, the higher value reflects more severity. So anything closer to 42 is more severe. Anything close to 0, less severity. All right. Um, let's see. Now, there are times that these tests are also done, or serial scannings may be used to assess the effectiveness of the treatment that we're giving these patients, and also to evaluate their recovery, see if there's any improvement, right? Now, an MRI is more effective in identifying ischemic strokes than a CT scan. But again, you will likely see them, the healthcare team, ordering a CT scan, a non-contrast initially. All right. And the CT scan, or the CT angiography, it just looks at the blood vessels of the brain to determine if there are any kind of perfusion defects. Right. Now, if the suspected cause of a stroke includes an emboli from the heart, diagnostic cardiac tests should be done. And so just think about these patients who go into atrial fibrillation. The atria are basically fibrillating. They're not squeezing. And so microclots do develop. And of course, they can break off and travel to the brain, blocking off the cerebrovascular or a blood vessel, leading to a stroke. Now, cardiac imaging is recommended because many strokes are the cause of a blood clot from the heart. So this patient will likely have a workup, cardiac as well as neurological. Blood tests can help identify conditions contributing to a stroke and guide treatment as well. Think about, for example, if someone is on Coumadin, all right, and it's supposed to prevent a patient from developing a stroke, and but it's not 100%. So anyway, but take a look at the table 57.6, and that will give you some additional information about that. All right, so sure if I'll be able to finish this one. Now, TPA, as far as medical intervention, tissue plasminogen activator, it is for ischemic or embolic type of strokes. It is not for hemorrhagic strokes. It will cause your patients to bleed. They dissolve the clot. Fibrinolysis, you know, the clot is a fibrin. It's made of fibrin. And the TPA lysis, you know, the lysis fibrinolysis, it breaks it up, all right? And so allowing more perfusion or reperfusion to brain tissue. Is given typically within 3 hours from the onset of signs and symptoms, but it can range as high as 4.5 hours if the patient meets certain criteria. A CT scan, again, must be negative. In other words, it has to be an embolic versus hemorrhagic. Labs must be within a normal reference range, glucose levels, platelets, INR. If those, for example, if your INR is too high, then they must be very careful in giving TPA because it can cause this patient to bleed even more. Say if a patient is on Coumadin and therapeutic INR is between 2 and 3 for conditions such as a DVT or atrial fibrillation. But then some patients have to be hypercoagulated if they have a valve, mechanical valve, and the INR should be between 3 and 4. So you want to check the INR and your platelets, of course, just to make sure they're not too high, because they may have to give them something to bring that down, like vitamin K in the case of an INR. Blood pressure must be controlled. The systolic BP must be less than 185 during treatment, as well as the following 24 hours. And the patient they should not have received a heparin or other anticoagulants. And so someone who's on Coumadin, let's see, what is it? Apixaban or something like that, Lovenox or what have you, they cannot have this treatment as well. And so I'm going to go ahead and stop this particular presentation as well. And so it looks like we're going to have 3 slides, or 3 presentations, if you will. Let me go ahead and stop sharing. And I'm going to stop this video.